Welcome everyone to today's webinar called Communication Techniques to Help Patients Find Their Footing with Fall Prevention. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman and I am the manager for the Fall Prevention Program at Parachute. I'm going to go over a few housekeeping items next, but while I do that, we'd love to see who is joining us today. If you can, please let us know your role, organization, and location. Just use the chat box for that, and that will give us a good sense of who is joining today. All right, time for housekeeping. During the webinar, if you have questions about the tech or general comments about the presentation, please use the chat box. I'll be monitoring this space for those types of comments. If you have questions for our presenters about their presentation, please submit those through the Q&A box, and that appears on your Zoom toolbar. So use that for specific questions for our presenters, and that will ensure that all of our questions get answered, and questions will be addressed at the end of the webinar. You will only be able to view questions you have asked, not questions posed by other participants. This webinar is being recorded, and a link to the recording will be sent to all participants in a few days, along with a link to the presentation slides, and our presenters have generously put together all the links that they'll be sharing in the chat over the course of the presentation. So thank you to our presenters for that. I just want to quickly remind everyone that our next webinar is on November 7th and focuses on exercise and physical activity to reduce the risk of falls. This is the first webinar in our Move, Improve, Remove series for Fall Prevention Month. And Tina's webinar is the first event as part of the series, and we'll be hosting 3 webinars in November as part of that series. And they're to celebrate the new posters that are available at no cost across Canada. You can just download them and use them for your own Fall Prevention Month campaign efforts, or all throughout the year for fall prevention awareness. And each webinar is going to focus on one of the 3 posters' calls to action: move your body, improve your health, and remove hazards. And again, all of this information will be shared in the post-event package via email. This is just a little bit more about those posters I just mentioned. Again, this information will be circulated, but the posters are available in French and English. They're targeted towards older adults, and they're designed to be posted in a variety of settings. So we hope that they meet a broad spectrum of people's needs. All right, many of you on the line are already Loop members, but for those who are not, we do encourage you to sign up. Loop is the no-cost online communication platform for the Fall Prevention Community of Practice. It uses its members and brings them together across Canada to problem solve and discuss how to implement evidence-informed and promising practices in fall prevention. So listed on the slide here are just a few of the services that Loop provides. And as a reminder, the recording link and the presentation slides will be posted on Loop in a few days. I'd like now to move to introducing our presenters. Andrea Martin is a program facilitator for the Southwest Self-Management Program and has spent the past 25 years working in healthcare, for long-term care nursing, home settings, to active adult community programming. And Nicole Seymour is an academic detailing pharmacist at the Center for Effective Practice and is experienced in both inpatient and outpatient hospital, pharmacy, family health teams, and academia. You can find complete bios for both Andrea and Nicole on Loop. So without further ado, please take it away, Andrea and Nicole. You can start sharing your screen now.
Thank you so much for the kind introductions, and thank you everyone for joining us today to talk about communication techniques to help patients find their footing with falls prevention. Moving on to introductions and disclosures, Andrea Martin is an employee of the Southwest Self-Management Program in the Thames Valley Family Health Team. And in this role, Andrea hosts workshops for both patients and healthcare workers in Southwestern Ontario, including training workshops in motivational interviewing and other health communication skills. So needless to say, Andrea is going to be the expert here. I'm an employee of the Center for Effective Practice, which is a federal not-for-profit organization that specializes in knowledge translation. I'm part of the academic detailing service that's funded by the Ontario Ministry of Health. In this role, I have one-on-one best practice clinical discussions with family physicians and primary care nurse practitioners with the goal of improving patient care. One of these topics is falls prevention. As a pharmacist, I also practice at St. Thomas Elgin General Hospital and dabble in a few other roles. I do not have any financial disclosures, and neither does Andrea. All of the resources will be put in the chat by my amazing colleague, Sachin Dugal, who is an academic detailing pharmacist as well with the CEP. And Michelle will also share these after the presentation, as she mentioned, and we will just take the questions at the end of the presentation. We'll start out by exploring some of the background related to why improved communication is needed for falls prevention. Although you're all here today, so I suspect you already have an appreciation for this. Andrea will share the principles of motivational interviewing, or MI. Full MI training is generally a multi-day workshop, and it takes a lot of time to practice and perfect. But hopefully will inspire you to incorporate some MI principles into your conversations with patients and maybe even explore some further training in MI. MI is just one of many communication strategies. We'll share some resources and tips to get you started with communication about falls prevention in general. Good communication is an underappreciated aspect of patient care and also of life. It's easy in a lot of ways and tricky in many others. Kudos to you for recognizing this and for being here today. In my academic detailing role, working with clinicians toward their goals of improving knowledge and skills, I'll show them CEP's nice falls prevention tool shown on this slide. Starting with the impact of falls at the top, how to screen for falls risk, and then we'll move on to the categories for falls prevention assessments and interventions. All of these strategies were part of a loop webinar back in April, if you're curious to look at that. Once we get past the whole issue of time making assessments and interventions challenging, there are often those super savvy folks that tell me, you know what, they know all of this stuff, but they just can't convince their patients to do anything that they suggest. They're worried about their patients and they have all these ideas to help them. So why don't their patients have any interest? Is it just them? Obviously not, or we wouldn't be here. A Cochrane review by Nyman and Victor found that across studies of falls prevention interventions, an average of about 50% of recommendations were actually accepted and fully completed. Uptake rates varied based on the intervention, with simple things like adding vitamin D and calcium having the highest uptake rates and targeted exercise having the lowest rates despite having the best clearly established effectiveness. A qualitative study noted that if falls risk was perceived as temporary and modifiable, patients were more likely to engage in prevention strategies. Understandably, they also found that those strategies perceived as being minor adjustments had better uptake versus the ones that were a little bit more imposing. And the perception about whether the falls risk and whether that strategy to reduce the risk aligned with self-identity also impacted engagement. Stevens et al. Reviewed facilitators and barriers to patient uptake of falls prevention interventions. I encourage you to take a look at this article as it bears many insights into beliefs and attitudes about falls that are fascinating and could be a whole webinar on their own. From this table, though, you may notice that many of these factors are related to communication. Much of these come down to ensuring patients understand their risk of falls and that falls are preventable, what the intervention actually is, how it's relevant to them, and the potential benefits to the recommendation, especially how it maintains their independence. The World Falls Guidelines specify that older adults should be informed of both the benefits and burdens of falls prevention therapy so that they can make an informed choice. The patient's knowledge and attitudes will determine whether or what type of intervention that they're willing to engage in. While this concept seems intuitive and easy, applying it to practice is not always smooth for many reasons. It's time to meet Murray. Murray is a 78-year-old who fell at a celebration of life for a family member. He didn't have any obvious injuries aside from a bruise on his arm and a sore ego. But his family insisted he see his doctor, who's a keener, and makes great progress in her assessments for falls risk. She notices he has a slow and unsteady gait, so she refers him to OTPT for an in-home safety assessment, consideration for an assistive device, and an exercise program. She also has some great ideas for optimizing his meds and wants him to come back in a month or so to review other falls risk reduction strategies. Murray is extremely annoyed by all of this fuss and wishes everyone would just butt out of his business. He thinks he's doing fine for his age, and he has no interest in making any changes. If you ask him, he'd say, "I just got tangled up in my own feet because I was rushing. It was my own stupid fault, and it won't happen again." So how do we make sure Murray is informed when he doesn't want to hear the word falls ever again? The way we communicate with Murray can help us. Using communication techniques such as motivational interviewing might help. So keeping Murray in mind as Andrea shares information about MI, we'll pick up our case in a bit and apply these skills after we've had some time to explore them.
Thanks, Nicole. Why don't we start off with a poll? So looking at having you share what you know about motivational interviewing. How familiar are you? And we'll let you vote in on this poll.
And Andrea, just going to confirm, can you see how many people have participated?
No, we can't see that.
Alrighty, so yeah, I'll keep you posted.
Thank you.
We've got some good keeners on the line, so thanks everybody. We're at 77, 78, 90. We may even get to 100. That would be fantastic. I'll leave it open for another minute or two. We seem to have plateaued. I'll let everyone get the chance. Some more trickling in. We're at 87%.
Well, that's great. Thanks, everyone.
Yeah, so I'm going to, oh, there was another one. It's always so hard to know when to close it. We're almost at 90. All right, I'm going to end the poll and share the results.
All right, so we're kind of all over the place. So I've heard the term, I know the principles, those are kind of tied there. It's new to a few of you, and I have a couple pros on the line. That's awesome, because we could maybe use your help when we get to the questions and answer. So thanks. I have a second poll because now I'm going to kind of ask you, see what you really know about motivational interviewing. So what do you think the goal is? We'll see what everybody's thoughts are in a moment.
Again, everyone's very quick to respond, so thanks everyone.
Great.
I'll give it another little bit, see if we can get the same amount of people to answer. Alrighty, I'm going to end the poll and share the results.
All right, so 81% suggested B was the accurate goal, and you are right. So most of us are on the same thought process as to the goal of motivational interviewing. If you chose C, although some of the skills that we use within motivational interviewing do help improve self-esteem, the goal really is that number B there. And for those of you who think that A might be the answer, although we have a wealth of knowledge to share with our patients, if we don't listen to them and then just go ahead and tell them what to do, we run into the risk of those patients feeling a lot like Murray did, wondering, what all this hype is all about. So let's look at a definition of what motivational interviewing is. So supporting patients to make behavioral changes is challenging. Motivational interviewing has been found to be an effective way for clinicians to support the change in patients that they are working with. According to Bill Miller and Stephen Rolnick, you see the reference in the bottom there from their book, Motivational Interviewing, Helping People Change, the 3rd edition. They share that 25,000 articles and 200 randomized clinical trials have shaped how we view motivational interviewing, how we use it, and how we share this with health professionals to this date. So let's start with the definition on the screen there. So motivational interviewing is a collaborative conversation style to strengthen a person's own motivation and commitment to change. It's a conversation about change, a person's own motivation and commitment to that change. I'm wondering what words in this definition kind of speak to you. Are they words like collaboration, conversation, a person's own motivation? So when we talk about MI, it's a way of talking and being with someone to support them. It's a collaboration, it's a conversation, it's never a lecture or a monologue. So MI is about addressing where the person is at. People who are ready to change don't necessarily need MI. This really is for those people who are ambivalent, which is surprisingly a lot of us. So I have a third poll for us to take a look at. So now hearing this definition, I'm wondering, what are some perceived barriers to people actually using motivational interviewing in the conversations they have with their patients? We'll see how fast people rank this poll then.
It's a quick group today.
That's good.
Yeah, everyone is on the ball. Great, I'll give it another second or two. And I'm going to end and share. Okay,
so some are feeling all 3 of these could be potential barriers to implementing motivational interviewing. The middle one, B, is kind of the highest with 63%. So you're not just trying to do that. So motivational interviewing can be taught. Anytime we do look to change the way we talk, it does take time. But it's really about being purposeful with the way we talk and the use of skills and strategies in MI. So I'll share some of the skills and some areas that we can actually get some training later on in our workshop. The lowest one was C, that it's really hard. I'll answer this with this idea that motivational interviewing is a journey. There's no perfect conversation. There's no script. It's a conversational communication tool to help you listen to what the patients want help with. So it's the idea of being with the patient. And at first, it can be challenging to shift in that. But after that, just being with the patient is actually very freeing. And then we have that it takes too long. So a lot of people worry about this. And it's interesting, a study that was done in Switzerland at a university hospital in Switzerland, it actually had physicians use a stopwatch at the beginning of the visit, and then they stopped when a patient indicated that they were ready for the physician to take over, saying something like, I wonder where I should go, or I wonder what I should do now. What they found was that 80% of patients finished talking in 2 minutes if they were left uninterrupted. So it's interesting to think that, the majority, well over the majority, do this within the 2 minutes. So, and sometimes it's looking at the idea that if we spend a little time up front, we'll actually save more time in the long run. So let's take a deeper look into what I mean and what all this is about motivational interviewing. So these skills and strategies are to be used in change conversations. But really, motivational interviewing is a philosophy. It's a way of being. If you have participated in MI trainings in the past, you'll be aware that a lot of time is spent talking about something called the spirit of motivational interviewing. It's a different way of working with patients. So as health service providers, a lot of a training is about learning the best way of doing something, the way that people, if they do this, they'll get better. And then telling our patients really how to do that. We have a lot of knowledge in certain areas of health. And if it worked well to tell our patients just to do something, we'd have a lot of really healthy people in our community. So we know it doesn't necessarily work. So motivational interviewing is a way of working differently with our patients to having different outcomes. What motivational interviewing is not, it's not about tricking people into change. It's a way of activating their own motivation and resources for change. So the way we communicate can change the outcome of a conversation. So you heard me talk about the spirit of motivational interviewing. So Bill Miller and Steve Rolnick, who really are seen as the gurus of MI, coined this term, the spirit of MI. This idea that MI is not just about techniques, not just the words, but it's also this underlying perspective. Without having this underlying perspective, the communication techniques shared really are a way of manipulating people into doing things that they don't really want to do. Sometimes it's similar to like a sales pitch you might have in the past. So this the spirit of MI really is this intersection of collaboration, autonomy, compassion, and evocation. So let's just look quickly at all of these. So this partnership or collaboration really is about working with the client, recognizing their strengths and supporting with explicit partnership statements, things like, I'm here to help you, or we can work together to find out what you want to do. When we talk about this autonomy or this acceptance, it's about accepting what the client brings. When people experience themselves as being unaccepted, they're really immobilized. And when people experience being accepted, they really are free to change. Evocation is this idea of focusing on the person's strengths and resources. Be curious and spark curiosity in the person that we're working with. A lot of talk about change stems from this idea of this person is lacking something within them. With MI, the idea is that the person has within them what they need, and together we will find it. Compassion is about leading with the heart, to actively promote the other's welfare, to give priority to the other's needs, and to listen to what is really important to the patient that we're working with. This spirit of MI can be, it's kind of like being the soundtrack to the conversation about change. When we look at a conversation, the spirit of MI is the most important reason that MI works. But another part is to pay attention to how people talk about change. All conversations generally follow 4 stages of a conversation. And these processes or these stages are this engaging, focusing, evoking, and planning. You do it when you meet a friend on the street. You'll go through these 4 processes. With MI, in the conversation, the engaging is about making a connection, creating a partnership, people who feel comfortable to share information is very helpful. And of course, the more information that we have as health professionals, the easier it is to support them in the way that is helpful to them. It's really about asking, shall we talk about something? When we focus a conversation in motivational interviewing, this focus is around behavior change. If there isn't a focus, it isn't an MI conversation. The focus of the clinician may not always be the same as the patient. So something we need to remember. Evoking is the why in the conversation. Patients who are more ambivalent may spend quite a while of time in this, exploring how they feel about change. Others who are maybe less ambivalent may spend a shorter period of time exploring their thoughts. And the last piece is this planning, or the how. In an MI conversation, you may or you may actually not get to this planning phase. We're going to take a look. I just want to introduce you to what are called the OARS skills. So the OARS communication tools of open-ended questions, affirmations, reflections, and summaries allow us to have a conversation about change. These skills take time and practice to be effective in an MI conversation. And I'll just highlight a little bit about each of those, and then we'll pull it together in our scenario with Marie. So open questions. We know that questions can be open or they can be closed. Closed questions collect specific bits of information. And if we use a series of closed questions, it really has an impact on the engagement. Open questions tend to get more information as well as things that we may have missed when we ask those closed questions. Open questions are a great skill, but they're not the only skill that we want to use in a conversation. Asking open-ended questions is less demanding on our patients, and it's really easy to get caught up in that question answer trap. And that leads to the patient being less passive, or being more passive and less engaged in the conversation. So using things like affirmations allow us to share back to the client their own strengths, and this greatly increases a person's willingness to be engaged and take on new tasks. So often we do the opposite and we focus on what is wrong with the person. Now, there is a difference between an affirmation and praise. Although we often like to hear praise, it does have some downfalls. When we give someone praise, it creates this power imbalance. The person giving the praise has more power. Sharing affirmations allow us to move away from the power imbalance and really highlight the strengths of the patient or their values that they have, what they carry into the conversation. A reflection is the next one to take a look at. So most of us can easily come up with a really simple reflection, really staying close to the words that the client has used and sharing that back. And it's good and it's effective early on in the conversation, especially when we're trying to build that relationship and really engaging the patient. It lets the client know that we've actually heard them. We want to move towards change. Simple reflections make this movement slower. So learning how to use something called the complex reflection or a deeper reflection really adds meaning or emphasis to the conversation of what the patient has says. And it can really gain some great momentum towards exploring their thoughts about change. The depth of the reflection increases with the amount of practice we do using reflections in our conversations. And the last one to take a look at is our summaries. So summaries pull together several thoughts that a client has shared. These are reflected back in a summary of the items. It's really your judgment on what you pull of the conversation to share back. A summary can be used throughout a conversation, and there are several ways that we can use them. There's a collective summary that shares back a number of interrelated items. There's also something that we can link summary where you reflect back what a person has said at the beginning of the conversation and to what is important later on in the conversation. And there's also this idea that we reflect back and share those thoughts immediately, and summarizing allows people to hear lots of different aspects of the same thing. So being able to use this reflective summary of the ambivalence that they're experiencing allows the client to see this ambivalence and then move the conversation towards change. So our OR skills are used throughout conversations to understand, to focus, to plan, guide, and propel the course of change. We can become very skilled at using these to deepen those conversations, really deepening the relationship and to help people explore how they feel about change. When these are used within the spirit of MI, we can actually help people make that change. Many of you will be familiar with motivational interviewing, and what we see in our MI workshops is that our health professionals, have a pretty good basic understanding of MI, and they believe it will be helpful, but they really struggle to use it with the patients. So we've seen health professionals, doing a good job with open-ended questions, and often those simple reflections are something that they do regularly and do well. But then the struggle is to really take it to that next level, to really deepen that conversation. The deeper the conversation, the more effective you are with those individuals who are struggling with that behavior change. It's when we have a deeper conversation, it allows our participants, our patients, really to focus on their feelings about change and how and where they are sitting within the ambivalence of change. All these skills take practice and feedback to be effective. I mentioned earlier that motivational interviewing is a journey. Skills build on each other, and with practice and feedback in that safe space, they allow you to grow your MI skills and continue your journey. So I really do encourage you to seek out some education to really work on those MI skills with that feedback. So today I've shared a little bit about motivational interviewing and some of the communication skills that are used within the motivational interviewing approach. So let's take a look at MI in action. So I do have 2 videos I'm going to share. So the first video is an ineffective physician using non-motivational interviewing approach when they're working with this patient. The second video shows the same provider who now uses motivational interviewing in their conversations. So these videos were produced by the University of Florida Department of Psychiatry, and they're funded by the Flight Attendant Medical Research Institute. So we're able to share these videos so you can see what they look like. So when you are viewing this video, what I'd like you to pay attention to are the things that the physician says and how the patient responds. So notice what the physician does that's ineffective, and then you can just put your thoughts into the chat. So I will pull up the video so we can take a look at this. Sorry, didn't click on that. Let me try that again. Here we go.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, I mean, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. He gets really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I mean, I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I mean, I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard. So I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. Everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
So what did you notice that physician did that has had an impact on the patient? Or what did you notice that the patient, like how they responded? Just throw some of your thoughts into the chat and we'll take a look at, what you found was ineffective when we watched that video. There's lots of thoughts going in the chat here. Guilt, patronizing, very closed body language, didn't acknowledge the feelings, lack of empathy, one-sided conversation. Patients seem to close down. Yeah, it's a shame, feeling judged. Oh, you got it, all that judgmental, guilt. Oh, yeah. It was pretty easy to pick out some of those not so great thoughts that I'm sure the patient was feeling. Oh, there's a nice big one there. Oh, thanks for putting that in there. We saw blame, scare tactics, telling the patient not what to do, cutting the patient off, didn't really listen when we heard the patient saying, the patient multiple times said that they were struggling, and that was not picked up by that. So, yeah. So lots of opportunities for that patient to do and talk differently to have a different outcome. And someone else put too much info. There was a lot of information, right? You could do this, you could do this, and she just listed them all out there. Okay. So let's see this happen, this whole conversation, but this time what we're going to see is the physician actually using a number of those motivational interviewing skills. So let's see how this looks now.
Watch what happens this time when the provider cues into what the parent is saying, empathizes with her situation, and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden.
Okay.
I did want to talk to you, though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you were able to stop. But they don't feel as scary to you now.
No, I mean, we're two separate people, and like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
You're doing the best you can do.
Yes. Yeah.
Okay, but it sounds to me too like part of you really does want to quit.
Yeah, I know that I need to, and I keep every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
probably like a 5, kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you, and sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure, it feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
All right, so that time around, we saw a very different outcome from the patient. So again, think about what you saw from the patient's perspective or what the physician did that was different that you liked. You can throw that in the chat while I switch screens here. Okay, so we're seeing the non-judgmental, the patient was receptive, validating her, actually truly listened to what the patient was saying. So we saw empathy, let her talk, lots of open-ended questions. You saw scaling questions. We saw evocative questions happen. More a two-sided conversation, right? The patient was doing a lot of talking in that conversation. The readiness for change, and we saw that scaling question in that. So we saw lots of good stuff focused on the patient's point of view. No scolding, no lecture. It really was about eliciting what the patient wanted. And it left the patient ready and willing to have a further conversation about, looking at quitting smoking. So thanks for all your thoughts. Those are great thoughts in there. So why don't we take a look now at using these skills back with Murray?
Yeah, thanks so much, Andrea, for the excellent overview. And this group is really bang on. They're picking it up really, really quickly. I can see all sorts of great answers in the chat, even since you stopped reviewing some of them. So again, let's kind of figure out, how do we start this ORS approach with Murray?
So if we were to ask Murray some open-ended questions, something like, what matters the most to you about, how you live out the rest of your life, or if you could improve anything related to your life or health, what would it be? We might be able to get some information that will help us in figuring out what it is that Murray wants to start with, or what we can help them to support him to make some of those changes. Some really evocative questions to make him think about that. So if we were to ask those questions, we might get information like this. We might get, find out what Murray really feels strongly about, how he wants to live out the remaining years. We might find out that, he wants to live at his own home. He does not want to burden his daughter. We'll find out about his loneliness. We may find out, that he's really annoyed about having to rush to get to the bathroom. And so those are some great things that we can work with that now we're getting from Murray in those conversations.
That's amazing. So, I mean, if those are his problems, I have solutions for all of them. We could do a home safety assessment and improve his general health to address his independence and also make sure he's not worrying his daughter. He could take up some walking or congregate meals to help with that loneliness and get some social activity. I can think of a few medication assessments or the Go Here washroom locator app, maybe some bladder training, adult underwear, or maybe consideration for prostate surgery for that bathroom complaint. I'm really excited. I have all these things that I could offer Murray that would be a win-win and address all of his goals. Should I share them with him, or can we jump right into the problem solving mode now?
Well, not quite yet. If we jump in too quickly to fix without knowing what Murray really wants, we risk really putting Murray on that defensive. And we want Murray to be engaged and an active participant in his health. So if we go to the fix too quickly, Murray will really feel like he can't do any of those things that we're throwing at him to do. So something we can try and look for and actually use is affirmations, really, to help build his strength in what he can actually do. So share back those strengths of what those values, and really build on his self-confidence to create this willingness to take on a new task. So some potential affirmations for Murray might sound like what we have on the screen here. You really care deeply about your daughter and continuing to be strong, independent father for her. Or something like, you took care of your wife and put her health forefront and while she was sick, right? So really bring out those core values of the strengths that Murray has.
Yeah, and I can see that the affirmations would make Murray feel like the clinician has a better understanding of his perspective. Hopefully, he's slowly opening up a bit more. The walls are coming down. He might say something like, "Yeah, my daughter's really busy, and I want her to not have to worry about me on top of everything else." And maybe something about how his wife used to do all the planning, and now he doesn't even know where to start to do something social. Or maybe he says he really enjoyed seeing his family, and the event reminded him how nice it was to enjoy a good meal with company. Let's say he shares something about how he was rushing to the bathroom when he fell, and he's still worried about being tied to that bathroom. So, what's next after you kind of get his walls down and you get all this information from him?
Well, one thing we can do is to use our reflections in that conversation. So it's helpful to reflect back any type of change talk that you heard in that conversation. So we're looking for words, preparatory words, perhaps like I want, I like, I wish I could, or I have to, or I've got to. Those are some preparatory words we're looking for. Or maybe we're looking for even some more mobilizing change talk. So that would be words like I've decided to, I intend to, I promise, I'm willing, I'm ready. Those are those more preparatory words that we know is moving him towards some level of change. When we hear more and more change talk and deepen those reflections that we share back, the conversation will deepen and actually move closer to change. So on the screen, there's some suggestions of what you might hear. You enjoy a meal out with others. You've put your life on hold and you miss getting together with family and friends. Or maybe it's something like being tied to the bathroom is a nuisance and you would really like to get out with friends more often.
Yeah, and I noticed some of those reflections in the video that we showed before. So Murray is nodding along to all of this. He seems satisfied with your reflections. What do we do to move things forward and get on to the actual change of that we're going to suggest for Murray?
This is where something like a summary might be helpful. So in a summary, you're choosing what you are going to reflect back. And of course, it depends on where you are in the conversation. We can use a summary to confirm understanding. It can help focus the conversation, but we can also use it just to transition the conversation from finding out information, now moving in towards more of that planning stage. When a patient is engaged, you have an opportunity to really provide the information with the patient as well. So maybe it's also looking at ways that we can give more information, using tools like a behavioral menu or the ask, tell, ask model of providing information. These are great ways of staying close with the spirit of motivational interviewing and still sharing that information to help Murray look at what he might implement in his life when he's ready for that change to happen.
Yeah, that all makes sense to me. And I remember hearing a lot of those phrases and terms and, where would we start? That was in the video that you shared as well. So I can totally see how this might relate. All makes sense to me. And as you can see, Murray's a happier camper by the end of this. Now, Murray's case was overly simplified for the purposes of demonstration. Let's dive into some of the resources and supporting tools for success.
And I can start off with just a little bit about motivational interviewing training. So I work for a program called the Southwest Self-Management Program, and my program, like other programs right across Ontario, actually offer a wealth of self-management workshops as well as motivational interviewing. Many of us will actually offer that to patients health professionals to take. They all look a little bit different, but most of us are all hosting these virtually. So it makes it easy for health professionals to take a couple hours out of their day to come and join and learn, and, with some feedback to how to incorporate some of these MI skills into those conversations they're having with their patients. As well, the Center for Collaboration, Motivation, and Innovation is actually the organization that's licensed us to deliver this training to health professionals. And so on their website, they offer trainings as well. They also have a host of references and that you can pull off and use from their website as well. And the other thing I wanted to mention was this book, and there's an image on the screen there by Bill Miller and Stephen Rolnick. It's a really helpful book that coaches you to look at the different aspects of motivational interviewing. And so I referenced it earlier in the presentation. So those are some resources and kind of like the training piece that might be available or of interest to individuals as well. If you're just looking for resources, our website at the Southwest Self-Management Program has items like our Teach Back card, to check for understanding with our patients. We have a number of MI tools on there as well. And as well, you can see where all our workshops help. As I mentioned, the CCMI website also has some downloadable resources. Some things that might be of interest are the MI and the 4 processes. There's also brief action planning. So now that we've got patients ready to do the planning, how is a great way to coach them through that? So there are resources to help that. And of course, this ask, tell, ask. So when we have information to share, how do we do it and still stay within the spirit of motivational interviewing? So there's some great resources that are available.
Perfect. And thank you so much to Sachin for throwing those in the chat. These will be shared again after. There are many, many strategies and resources of note for both communications and falls prevention. An important consideration is effective collaboration and communication between team members to optimize initiatives and also share important information gained through the MI process can be helpful, as it may relate to the other providers as well. The World Falls Guidelines specifically recommend caregiver and family support and perspective to enable adherence for patients who have cognitive impairment, but family and caregivers can also sometimes aid in gaining perspective, barriers, and implementation regardless of a patient's cognitive status. One thing to keep in mind is the role of the clinician. The Dignity of Risk and Falls in Older Adults webinar through Loop earlier this month did an excellent job at exploring the role of providers in sharing information and recommendations, remembering that patients bear the ultimate power to accept recommendations and also to accept risks, assuming they have the capacity to do so. Making sure we are effective in our communication is key to ensuring patients make that informed choice. There are many sites and resources for patient-friendly education material that we don't have time to explore, but take a look at your own resources and see if there are any opportunities to improve. The CDC study program has some carefully designed brochures if you're looking. They also have communication design guides to aid in conversations about falls using a few techniques. This is a quick preview of a one-page CDC study clinician discussion tool, which asks first whether the patient recognizes their risk of falling with some talking points to assess and respond depending where they're at. They then suggest exploring whether the patient understands the benefits of and barriers to adopting a strategy. And then the next slide shows how they recommend following an assessment of the patient's self-efficacy and readiness for action. They build in tips and talking points throughout. There are 2 other helpful and more comprehensive guides from the CDC study program that aid in these conversations as well. The fact sheet is a deep dive into various scenarios, and talking points about falls prevention sheet utilizes another approach with that stages of change model with questions and responses depending on the readiness assessment. Regardless of what you choose, the MI principles can be built in, and you may even notice some of it in the undertones of this work. In summary, patient engagement in falls prevention recommendations isn't always great. but has been correlated with several factors related to communication. Patients do have that ultimate choice of whether to participate, and our role as healthcare providers is to ensure that we do our best with communication so we can ensure patients have all the necessary information to make that informed choice. If you have been able to effectively communicate and the patient still says no, you have done your job and you should feel good about that. MI is a collaborative conversation style to aid with this. And as Andrea mentioned, MI is just one of many techniques. There's no one size fits all for communication. We need to adjust to the patient, including accommodating for things like language barriers, low health literacy, hearing impairment, vision impairment, cognitive impairment, cultural differences, preferences, among others. This isn't always easy, but it gets easier with practice, and you have to start somewhere. We're all just doing our best, and kudos and congratulations for taking the step of being here. We have our references on our next slide, and I'll say one more time because it's really important. Good communication is an underappreciated aspect of patient care and of life. It's not always easy, and it can be tricky in many ways. So thank you for recognizing this, for taking steps to improve your own skills, and for joining us today. We're really hoping we're able to share some things that may be worth trying in your practice, and we're happy to answer any questions now.
Thank you so much, Andrea and Nicole, for a really practical, interactive, and thoughtful presentation. You somehow did it all. We did have a few participants submit their questions in the Q&A box throughout the presentation. So I'll give folks another moment to get any last-minute questions in that Q&A box so that we can answer them. I'll also just want to remind people that at the end of the webinar, a evaluation survey will pop up automatically. And if you can fill that out for us, it'll help us to continue to put on high quality webinars for you. And we love to hear from the community. So thank you. So I'm going to turn my attention now to the question. I see that there's one about the tools. I think that must have been answered after you went through all of them. So that's fantastic. And a reminder to everyone, in my post-event email, there'll be a link to the slides, link to the recording, all of the resources that were shared in the chat today. And I'll also provide Andrea and Nicole's contact information. So you'll be getting all of that to your email. So moving on to Laura's question. She says, I work in stroke rehab. Any tips to apply these techniques when our clients have executive dysfunction, impaired short-term memory, poor safety awareness, dementia, etc.? So a cognitive impairment questions are always popular. So thank you for asking that question, Laura.
That's a whole webinar on its own. Yeah, definitely appreciate the challenges with that. Andrea, do you have any tools or resources here?
All that I would suggest was, when I talked about that spirit of motivational interviewing, that compassion, that acceptance, especially when we're dealing with dementia clients, that's what they're feeling. So keeping in mind that that heart, the compassion in how we coach them is something that they feel, even though that dementia is stopping them from having some of those conversations, at least how we're used to. So it is challenging. And if we're looking at putting in place some of those behavior changes, they may be also having individuals support them. So working with their support using tools like motivational interviewing and action planning may be most appropriate when you're dealing with those people who are caring for them as well. That was just some thoughts that I had when I first looked at that question.
Yeah, and I don't have as much for the cognitive impairment, but I did actually come across when preparing this slide deck, the Aphasia Institute actually has some pictographic resources for people that have different types of impairments, and doing kind of pictures and showing things in that term can be really helpful. And they do have a guide talking about falls prevention working together. So that might address some of the communication techniques.
Awesome, that's fantastic. Thank you both. All right, so those were all the questions that were asked. I think clearly the presentation was nice and comprehensive. There's not a ton else to ask, so thank you so much for that. But there was clearly a ton of engagement from participants in the chat box. And if you turn your attention, if you have the chance now, there's lots of words of thanks. But again, I will share the chat box information with you, both our presenters. And thank you again. And to Sachin, thank you so much. Doing the real work of sharing all those links, it's a huge help. So thank you. And I hope everyone has a fantastic rest of their day.
Thanks, everyone.
Yeah, thank you.